Welcome to Part 4 Care of Patients with Malnutrition or Obesity lesson. In this lesson, we will discuss the different body system alterations affected by malnutrition or obesity. We will also discuss the laboratory data associated with malnutrition or obesity. The body experiences a metabolic response with alteration of proper nutrition. The sympathetic nervous system is stimulated. The adrenal medulla releases epinephrine and norepinephrine. Other hormones are released such as glucagon, ACTH, ADH, cortisol, and aldosterone. Nutrients, other words amino acids, are taken from the peripheral tissues to the liver for glucogenesis, which results in hyperglycemia and a negative nitrogen balance. You will assess and interpret clinical manifestations or alterations that a patient experiences with inadequate nutrition resulting in malnutrition or obesity. In the cardiovascular system, the patient may experience CHF, cardiomegaly, tachycardia, cardiomyopathy, cardiac dysrhythmias, myocardial infarction, and hypertension, which we generally recommend a DASH diet. They may experience heart failure, which we will recommend several small meals per day. And they could also experience cardiac cachexia, and we're going to recommend a calorie-dense, high-protein foods in small volumes. In the pulmonary system, the patient may have a decreased surfactant production, decreased diaphragmatic mass, decreased vital capacity, and decreased immunocompetence, COPD, which puts them at risk for cor pulmonale. Recommendation is for prevention rather than correction. They are also at risk for fluid overload, potential with internal and parenteral nutrition therapy. We're going to provide meats, poultry, cheeses, yogurt, frozen yogurt, and ice cream. They may have pulmonary edema or fluid volume excess. We want to recommend no more than 35 to 40 milliliters per kilogram per day of fluid. And there is an increase in CO2. Overfeeding results in the excessive production of carbon dioxide, which can be a burden in the person with pulmonary compromise. In the neurologic system, the patient may experience dysphagia, and they have an increased need for protein, calories, zinc, vitamin C, thiamine. Some of the nursing concerns, such as phenytoin with enteral formulas, actually decrease the effects of it, which equals a risk for seizures. They may experience disorientation, confabulation, neuropathy, and paresthesia. In the renal system, patients experience a fluid imbalance, therefore we need to monitor their fluids. They're not restricted until urine output decreases. And there's an equal amount of calories based upon calories spent. Adequate calories are needed to avoid catabolism. In the gastrointestinal system, the patient may experience liver impairment, which results in elevated circulating glucagon, epinephrine, and cortisol. It promotes catabolism of body tissues. There's inadequate production of bile salts, such as malabsorption of fat from the diet, and then proteins are used for energy sources, producing tissue wasting. Some of these examples are use of corticosteroids. An example is dexamethasone. The altered metabolism leads to altered carbohydrate, protein, and lipid metabolism, predisposing the client to obesity when they're taking these drugs on a chronic basis. Blood glucose and blood lipid levels are elevated, and this causes an increase in the client's appetite. They may also experience nausea and vomiting, diarrhea, stomatitis, chelosis, glossitis, magenta tongue, swollen bleeding gums, fissured tongue, and hepatomegaly. In the endocrine system, the patient may experience hyperglycemia, hypoglycemia, and hormone imbalances. Most common is diabetes mellitus. Glycemic control is challenging. Hyperglycemia results in increased rates of nosocomial infections related to poor diabetic control, infection, trauma, burns, or glucocorticoid use. Hypoglycemia is related to vomiting, poor food intake, or oral hypoglycemic agents. Alterations in the hair can include alopecia, corkscrew hair, or decreased pigmentation. The eyes will possibly have cirrhosis of the conjunctiva, the corneal vascularization, keratomalacia, or blot spots. Skin will appear dry and scaly, petechiae, ecchymosis, follicular hyperkeratosis, nasolabial seborrhea, or bilateral dermatitis. Extremity alterations include subcutaneous fat loss, muscle wastage, edema, osteomalacia, bone pain, or rickets. Hematologic alterations include anemia, leukopenia, neutropenia, low prothrombin time, and prolonged clotting time. So during the laboratory assessment, the things we're going to assess are hemoglobin and hematocrit, which low levels may reflect anemia. Serum albumin, which indicates the body's protein status. Thyroxine binding prealbumin, more sensitive indicator of protein deficiency. Serum transferrin, indirect measurement of total iron binding capacity. Serum cholesterol, low level is a possible indicator of malnutrition. Decreased renal excretion, as in acute or chronic renal failure. You want to monitor output if giving potassium IV or PO for risk of increased potassium. Medications such as potassium-sparing diuretics, beta blockers, and ACE inhibitors. What happens is there's a shift out of cells and it leads to acidosis, tissue necrosis, GI hemorrhage, or hemolysis. For hypokalemia, the rate is less than 3.5 milliequivalents per liter. There's an increase in renal losses, increased GI losses, potassium wasting, anabolism, refeeding, correction of glucosuria or DKA. There's low magnesium, which can inhibit the potassium ions, and possibly it could be from inadequate intake. Then you're going to check for hyperkalemia, which is greater than 5 milliequivalents. It could be due to decreased renal excretion, so you want to monitor output, especially if given potassium IV. You're going to monitor medications, and if it shifts out of the cells, you have acidosis, tissue necrosis, GI hemorrhage, or even hemolysis. Another lab we're going to monitor is serum calcium. The normal serum is 9.0 to 10.5 milligrams per deciliter. This includes ionized calcium and calcium bound to protein, primarily albumin and ions. In malnourished, you'll see low serum albumin. This could actually also result in false low calcium level. Normal levels are maintained by hormonal regulation using skeletal reserves. So for hypocalcemia, you have less than 9, and it could be due to hypomagnesemia, hypoparathyroidism, hypomagnesemia, renal failure, renal tubular necrosis, or just a vitamin D deficiency or impaired metabolism. Hypercalcemia is greater than 10.5. It could be due to hyperparathyroidism, some malignancies, immobilization, or even hyperthyroidism. Another lab is serum phosphorus. Normal is 3.0 to 4.5 milligrams per deciliter. Serum phosphorus is a poor reflection of body stores because less than 1% is in the extracellular fluid. Bone serves as a reservoir. Hypophosphatemia is less than 3. It could be due to impaired absorptions, medications, alcoholism, intracellular shifts, repeating syndrome, or increased losses Hyperphosphatemia is greater than 4.5. It could be due to decreased renal excretion, increased cellular release, or increased exogenous phosphorus load or absorption, or even acidosis. And the last laboratory we're going to discuss is hypomagnesemia, which is less than 1.3 milliequivalents per liter. It could be due to decreased absorption, renal losses, chronic alcoholism, inadequate intake, medications, intracellular shift, or refeeding syndrome. Hypermagnesemia is greater than 2.1 milliequivalents per liter. It could be acute or chronic renal failure. You want to monitor for depressed neuromuscular transmission, absent reflexes, or hypotension. This concludes Part 4 of Care of Patients with Malnutrition or Obesity. If you have any questions related to this lesson content, contact the instructor.